Thanks for tuning in to the Stigma and Discrimination Forum in Asia. I'm very pleased to talk to you online. I'm going to talk to you about U equals U, rolling out U equals U, the experience in Malaysia. But first of all, before I get into that, I want to just focus on stigma. Let's just start with the definition. The reason I'm starting here, and that's the book by Irving Goffman, sociologist, that everybody cites, but we're not really using Goffman's concept of stigma. And that's, well, you tell me whether that's a good or bad thing. So I have rather strong views. Let me just read out what Goffman had written, okay? And this is on the preface of his book, written in 1963. So he says, in this essay, I want to review some work on stigma, especially some popular work, to see what it can yield for sociology. An exercise will be undertaken in marking off material on stigma from neighboring facts. So stigma is very broad, as we know, and more things are being added in terms of diseases. So we have mental health, we have AIDS, we have poverty, anything can be stigmatizing. And the issue with being so broad is sometimes we're not very sure what we're looking at. And so please allow me to read this out. So in showing how this material can be economically described within a single conceptual scheme, and in clarifying the relation of stigma to the subject matter of deviance. Deviance is just a sociologist's way of saying, well, not normal, basically. So not deviance as in bad. This task will allow me to formulate and use a special set of concepts, those that bear on social information. The information the individual directly conveys about himself. So what does he mean by that? And in fact, stigma is all about information. We've been focusing on AIDS-related stigma. We've been calling it many, many different names, but it's the information that we share. And to explain this without using the word stigma, here is a t-shirt. So I wore this t-shirt in Geneva. I was running very late for my flight and my bag broke coming to the airport. So as I was approaching the counter, the guy said, "Ooh, where did you get that t-shirt? Who was it by?" You know, and it's just, you know, started to make a conversation. Well, this t-shirt was my information, the social information that I'm projecting. We all project social information all the time. So it's our names, who we are, what we are, and why we are, perhaps. Diagnosis and diseases and fears and qualms and emotions are all the kind of information that we project. The issue with stigma, and this is not very well established, unfortunately, in AIDS research, stigma is not the information that we project. Stigma is the recipient telling us that the information that we project is no good. So it's calling us out on the information that we project. If you see it this way, stigma is a relational concept. It does not really, it's not a label. We've been using stigma as a label, and we've been chopping it up: public stigma, self-stigma, implied stigma, lots of different types of stigma, but they're all just labels. Well, stigma as defined and conceptualized by Goffman is not a label. Now that I've sort of put that into perspective, let me tell you why this is an issue when it's a label. So because I was wearing this t-shirt and we started off having a conversation with the check-in desk, he helped me really beyond his duty to find something. I was running very late to find something to tie my bag. And it was really kind of him. But it all started with a little T-shirt. And this social information that we project and we daily use in order to get out to get around in the world is something that really fundamental in society. And stigma is when we do it wrong. And that's the key. It's not, the stigma is not a label on a person. Stigma is not a label on a thing. Stigma is a relationship between the information that we are projecting, social information that we're projecting, and the person's judging our information to see whether they agree, disagree, or perhaps have different views, okay? It is stigmatizing because they disagree. So we've been focusing a lot about patients who, AIDS-related stigma is mainly about patients, but you could also look at it for physicians. So if a physician does not do his or her job properly, according to guidelines, which are all published now, and the patient tells the physician, look, you're not doing your job very well, that is stigmatizing also, right? So it's not just a one-way street. Stigma is not just stigma to me, but stigma to anybody who judges social information. If you look at it that way, the whole landscape of AIDS changes. And this is something that became very, very poignant during the current COVID pandemic. I think I really needed another pandemic, a global pandemic, in order to realize that, look, we've been thinking that people are really afraid of AIDS. I think we're wrong. I think people are afraid of uncertainty. And I think people are really afraid to die, right? And the problem is public health has been weaponizing fear. And in some cases, it's really effective, but not long-term, and not when social information is concerned. And I want to tell you another story, not talking about Asia, but the other story is COVID in Switzerland. I'm not going to talk about Asia because Swiss has one of the best healthcare systems in the world. But this family, the whole family, extended family, became COVID positive. The initial case, when the son, a 13, 14-year-old son, contracted COVID, everybody was terrified. Okay, and this is Switzerland. Okay, it's not Malaysia, it's not Asia. They would leave his food out and then they would disappear. Right? They were that terrified, avoiding him. And this is not AIDS either, but we see this with AIDS. We call that stigma. We call that discrimination, right? Well, maybe it's not discrimination. Maybe it is inherent fear. And if it is inherent fear, and we've been calling it discrimination, then we've not been addressing the problem that the person has in the perception, the kind of social information that we send out. And this is what we really need to get to the bottom of. In the last 5 minutes, I've got 5 minutes left, I want to tell you a little bit about the situation in Southeast Asia. I'm not going to mention directly about Malaysia because I found out the hard way, I have to say, that Southeast Asians are really nationalistic. I think the world is. But Southeast Asia, especially because a lot of our countries have been colonized, and so we are rather nationalistic. And because of that, if we point out a country that didn't do as well, it's not it will be taken in a negative fashion. I like to group Southeast Asia as Southeast Asia, and this is what I'm going to do now. Now, in Southeast Asia, a lot of our health systems are not only government or funded, not only public health, but private it's almost like a dual type system that's operating in tandem. We have been focusing so much about public health from a community perspective, which is great, but we hear almost nothing about public health in terms of AIDS, in terms of ending AIDS, from the perspective of businesses. Why does this matter? Because if we're going to sell the idea that treatment is prevention, that undetectable is untransmissible, which is scientific, but like I said, it's a social information, right? We're sending out this social information, and the other person, well, they have to believe it. They have to accept it. If they don't accept the social information that we've been sending out, well, then they won't, and you'll find out about it because they'll let you know one way or another. If we can't get people to work, if people cannot work, then what is the good of ending AIDS? People must be able to live normal, healthy lives. And that does not mean they are all advocates and they all become peer supporters, although they're great. But I'm not asking people to work in NGOs. People must work in society. Well, we haven't heard really that much about this. And because in our part of the world, almost half, so now I'm going to focus on Malaysia, just on numbers. Half of the people on treatment are doing it privately. And we don't know anything about them. We've been counting only the people going through the government service. And we've been targeting the lowest denominator, okay, vulnerable people. But people are vulnerable in different ways. Just like stigma, vulnerability changes with time. It changes with our circumstances. And our circumstances changes the social information we provide. In closing, I urge you, please do read this book. In just the first 7 pages, really, just the first 7 pages, government tells you what stigma is all about. And I want to end with just this line. He says, in a bit tongue-in-cheek, he says, we are going after universal human rights. But he says, to be human and to be a universal human is not a very human thing. These concepts, human rights, equity, equality, are amazing. We are really looking forward and making sure that everybody matters. But it's aspirational. And thinking business-wise, we have to start counting the pennies where people are. We cannot be just aspirational. It's great, yes, but we have to have a roadmap to get there. That is not just treatment. It is living with HIV. Thank you very much.